Good day. We are going to start with a new chapter. And if you have seen the chapter in your textbook, this is a very long topic. And that is why it has been divided into two parts, Neoplasia 1 and Neoplasia 2. All the molecular pathology has been lumped into Neoplasia 2, and all the introduction and other concepts up to the time the disease is diagnosed, it is in Neoplasia 1. So we are going to start, and you have to see to it that you will be taking notes of new terms, because you will be hearing here new terms that you have not heard before. And that is how you're going to learn pathology. You keep on learning new terms and new concepts. So we will start with Neoplasia 1, and it is the second leading cause of death in the US. In the last decade, however, there is a decreased mortality, and this is explained by many factors. We will talk about that. Now, you have to know the nomenclature of the lesion, because these are synonyms. In the clinics, they still use tumor, see? But in inflammation and repair, you have learned that tumor is a swelling, which is due to edema and inflammation. But in the clinics, they still call the neoplastic growths as tumor. So do not be uh, do not think of inflammation. Think of neoplasia. It's a new growth. All right. So you see, neoplasia is equivalent to tumor as far as nomenclature. In the study of tumors or neoplasms, it's called oncology. So you study by oncology. Oncos means. What is neoplasm? Well, it's abnormal mass of tissue. Abnormal. There is no normal tumor. And when it grows, it continues growing. It is uncoordinated. You see, in repair, you grow tissue. In hyperplasia, you grow tissue, but it stops growing. Here, it is uncoordinated, and even if you remove the stimulus, it will continue growing. You see, that is why it is autonomous. It does not need any existing exogenous stimulus, because it will continue growing. Now, when we say clonal, we have a single cell that has genetic damage. So the clones we are going to talk about here are those damaged cells. Because normally in histology, you say you produce a clone of cell, one cell will divide into two daughter cells will divide into four daughter cells, and so forth. And the whole progeny of cells is called the clone. Now, when we talk about clones here, it means that the cell from which the other cells have originated have already a genetic damage, and it has been passed to all the daughter cells. Now we classify the neoplasms into two, a benign or malignant. Malignant is equivalent to cancer. So when it is benign, it is innocent, meaning usually there are no symptoms. The patient does not complain anything except for feeling a mass. And it remains localized, meaning it will not spread to other sites. And this is very good for the surgeon, because all the surgeon has to do is just remove it locally. And it usually does not lead to the death. The patient survives because it is just the mass that was removed, and it is relatively innocent or benign. Now, when it is malignant, that is the equivalent of what people know as cancer. When they say there is cancer, it means there is a malignant neoplasm. And take note that malignant neoplasms have characteristics that are different from benign, because they can invade, they can go outside of where they originally have grown, and as they go out and invade the adjacent tissue or the neighboring tissues, they are going to destroy the tissues. Now, sometimes this will spread But we mean distant sites is very far or far away from the original tumor. And if this is continuous, progressive, not cured, not removed, it may cause the death of the patient. Now you can see this diagram where you have benign as compared to malignant. The cells are not cancerous, they are just localized there and they will not spread to the surrounding tissue. But in the cancerous cells, you can see that they will break through the limiting membrane there and go out, and they are very different from the surrounding or the adjacent tissue. They can spread to other tissues, not only the neighboring tissue but also to distant. Alright, there are two components of neoplasia. You also know that in histology, there are two components of the tissue. The parenchymal cells, and the parenchymal cells do not just float around there. They are limited by a stroma or a support. See? Now, these clonal neoplastic cells are the parenchymal cells, and it is based on these cells that you will find how the tumor is going to behave, how the tumor is going to have consequences, or the outcome of the tumor. It depends on the parenchymal cells. Now, the support, the stroma, contains blood supply. You know that the blood vessels, capillaries are there, even nerves are there, see? And the framework or the support is made up of connective tissue. And that is usually fibrous connective tissue. Now, it depends on the uh, on the amount of the stroma, whether you will find the tissue soft or very, very hard. When you have only very scanty connective tissue, it is more on the parenchymal cells, you will find that this tissue is soft, it is fleshy. But when there is plenty of stroma, and that is fibrous connective tissue, and you know already that they also lay down collagen fibers, when you have plenty of these collagen fibers, the, the tumor, the neoplasm, becomes very firm. And sometimes it becomes stone hard. So the patient says, Doktor, meron akong bukol dito, parang bato. You see? Why? Because the stroma is very abundant and you have plenty of collagen fibers there. And this is one term you will now meet, which is new to you, desmoplasia. If you read that the tumor is desmoplastic, that means it is stone hard and there is plenty of stroma, there is plenty of fibrous connective tissue. That is why the example here is there is a cancer condition of the breast where there is plenty of stroma, and they diagnose that just to show that it is stone hard grossly is the serous type of carcinoma of the breast. So you will find here a piece of tissue. The lining there is made up on the right side. It is only one layer. As it goes to the left side, there are multiple growths of the cell, and you can see that this is the parenchymal cells. These are the parenchymal cells, and you have the stroma there, which is made up of spindle cells, but it is looser. So you have a looser connective tissue here, and most probably if you will feel this tissue, it is soft and it appears flesh. Alright, now this is cancer, and you can see now that there is the stroma, the relationship between the stroma and the parenchymal cells is such that you have now less stroma, you have plenty of those new growth. There is a new growth of the glands. So they crowd together, and you will see that the stroma is more scanty than in the previous one, and this can be firm. And the mesenchymal stroma, there is in between, the parenchyma is made up of the glands. And these glands are already in the stroma. They have already gone to the stroma. You know from your histology that these glands should be um, lining, although there are also glands that are found in the stroma that are uh, beneath the lining, where you have in the intestines, in the stomach, where the glands are more crowded and the stroma is less. Right. Now, how do you call the tumor? Normally, the rule is when it is benign, you just add OMA to the cell of origin. So osteocytes is osteoma, chondrocytes is chondroma, fibrocytes are fibromas, lipid-containing or adipose cells are called lipoma, and this is another one. Whether it is benign or malignant, when it indicates glands, you add the prefix adeno. So you have glands of the stomach, you have an adenoma of the stomach when it is benign. Glands of the intestines, you have adenoma. Adeno meaning glandular. Take note that the nomenclature is becoming little. Now, you can see the pattern of growth. In the right side, in the gross specimen, there are overhanging projections. They are actually finger-like projections from the mucosa, and they hang down like that in the lower part. They go up. But the section you can see is that you have a projection into the lumen. So on both sides, you have normal tissue, but as it went up above the apex of the stroma, you will see now the crowding of the cells, and you have a finger-like process pointing upwards, and you call this a papilloma. Take note there is a short stalk, but if the stalk becomes longer, you call it a polyp. It is also projecting into the lumen. You can have a nasal polyp that is projecting into the nasal cavity so that you will have a difficulty in breathing. Now, another complex part of nomenclature, what if it is glandular and then you see big spaces? And spaces are called cysts. So you have cyst adenomas. What have you learned here? There are spaces, it's glandular, and it's benign. Now, when you have those finger-like processes with cyst and it's glandular, you have now a papillary cyst adenoma. So from the name alone, you have already information about the tumor that it is projecting into finger-like processes. There are holes inside, it is glandular, and it is benign. 4 facts in one name. Now, when it is malignant, you call it carcinoma. And now it depends on your embryology. Where is the tissue derived? Is it epithelial from the 3 germ layers, or is it mesenchymal or in the stroma? Epithelial, 3 germ layers, you have adenocarcinoma, meaning it is glandular cancer, or squamous cell carcinoma arising from squamous cell, basal cell carcinoma from the basal cells, and sarcoma when it is mesenchymal. So where is the mesenchyme? Again, you have your supporting tissue, your adipose tissue, liposarcoma. The muscle is myosarcoma, but there are 2 types of muscle. The smooth muscle is leiomyosarcoma. So one name, you know it arises from smooth muscle, osteosarcoma from bone, fibrosarcoma from fibrous tissue, chondrosarcoma from um, cartilage, angio meaning blood vessel, angiosarcoma from blood vessel, and this is the other muscle, rhabdomyosarcoma. This is striated muscle. So leiomyosarcoma from smooth and rhabdomyosarcoma from the muscles. Take note also of the pattern of growth. All of these are carcinomas. They are malignant. They arise from the lining epithelium, But on the left side, you have a growth that is producing the finger-like processes, and you have a papillary carcinoma. Take note that the base of that papillary tumor is flat and it is straight both on the left and right side, which is normal supposed to be, and it has not gone beyond the basement membrane. Now, on the right side, it is still papillary, but what do you notice? That it has gone down up to the muscular layer. What does that mean? It has invaded into the lower layers, and so it has gone beyond the basement membrane, it has broken the basement membrane and went down. It invaded. So it's still papillary. You have the finger-like processes, but now it is invading. So you have an invasive papillary carcinoma. Actually, if you make the complete name, a papillary adenocarcinoma, because it is glandular in origin. Now take note again on the left side. It is still the carcinoma. There is that thickening there, but it is flat. And take note that it is not going beyond the basement membrane, so it is not invasive. Still adenocarcinoma that is flat, non-invasive, and CIS is called carcinoma in situ, meaning it has not yet gone beyond the basement membrane. Now, on the other hand, that can also invade. And you will see now that the basement membrane is broken and it has gone down to the muscular layer. So you can also have a flat type of tumor where it is invasive down, the basal cells go down there, and you have still the cancerous growth. All right, other types of nomenclature. Sometimes you have a single neoplastic clone. Remember, there is already injury to the nucleus of the cell, but there is what is called a divergent differentiation of a single clone, meaning it will not differentiate, it will not mature into just one type of tissue. When you say divergent, there are different types. It diverges, see, to different types. So you will find, for example, an adenoma of the salivary gland or parotid gland, for example, where it is not only one type of tissue that will be formed by these divergent clones, they will form other types of tissue because they diverge from that single clone. And so, halo-halo na, no? There are different types of tissue, so you call it a mixed tumor. And adenoma, you can also have a malignant adenocarcinoma of the salivary gland, but with divergent differentiation of that clone. Now, this is also halo-halo because you have also different types of tissue, but it did not arise from a single cell. It arose from a totipotential cell. Now, what is a totipotential cell? It is a cell that has the possibility of differentiating into different types of cell. So, it will differentiate along three germ layers, the ectoderm, the mesoderm, and endoderm, and it can also be benign or malignant. Now, when it is mature, benign, the tissues that you will see in that tumor are all benign. But when they will have malignant characteristics, then it is usually the immature type with the malignant characteristics. And you can have a malignant teratoma. Now, one of the examples here, which is very common, is to find an ovarian tumor. So the obstetrician has a patient with a mass in the ovary, and when she operates, after the operation, she's going to open up the ovary and will find out that the ovary contains hair. Can you imagine a tumor containing hair? Not only hair, she may find a tooth, she may find a part of the eyeball, She may find secretions, sebaceous secretions inside. So, sabi ko na nga ba, halo-halo din. But it arises from the totipotential cell that will differentiate into just specifically 3 germ layers. So, on section, if you will find the wall of that ovarian tumor, you will see skin, you will see sebaceous glands, the other glands. You can see even cartilage, even nerve cells. You can see they are derived from the 3 germ layers. So you can have a benign teratoma or a malignant teratoma. Both of them have different contents, but the origin is different. So you have also another one, which is a misnomer because it's called a hamartoma. Nowadays, it is already um, recognized as a benign tumor. You see, this is a mass, but it is disorganized. It is benign. There are no malignant characteristics, but these tissues are indigenous to that site. So, for example, in the lungs, what do you have in the lungs? You have cartilage, you have blood vessels, you have glands. So, it is also a mixture. It is also a mixture. And you can see here in this hamartoma sections of cartilage, glands, and other tissues. And you can see blood vessels. So you have a pulmonary, because all of these tissues are inherent, indigenous. They are normal there, but they are already disorganized. So it is chondroid. You have a hamartoma with a hemangioma. So you have blood vessel also. Now another one is you have rest of normal tissue. Ito parang napaligaw lang. Normal tissue siya, napaligaw. So you will find, for example, in the mitral tissue that will be diverted to another organ. So you have here glandular tissue, and then you find these endometrial glands. So they call it endometriosis, and it is called acoristoma, where you have rest, heterotopic rest of normal tissue. This also occurs in the intestines. So a patient with intestinal obstruction is brought to the hospital. They get the x-ray and they find a mass that is protruding into the lumen of the colon, producing the obstruction. So when they operate and they see the section, what did they see? They see pancreas, normal pancreas that is found under the mucosa of the intestine. Anong ginagawa ng pancreas sa intestine? Napaligaw lang, heterotopic rest. And that is normal tissue. Here it is normal tissue. Now, this you memorize. Di lima lang naman yan. Memorize it. So that when it is given to you, you know that it is not benign. It is named benign, but the characteristics are malignant. So hepatoma. The correct name of hepatoma is hepatocellular carcinoma. See? You have a lymphoma, seminoma, melanoma. Oh, melanoma, you have melanin cells become malignant, and it is supposed to be a melanocarcinoma. Alright, mesothelial cells, mesothelioma. They should be mesothelial sarcoma. So, they have malignant characteristics, but they have a benign name. Oma din, pero malignant. Memorize. Now, we said you have a divergent differentiation. What do you mean by that? It is not just maturation. It is the extent to which the cells resemble the normal. So, saan nyo napag-aralan ng normal? Sa histology. If you don't know histology, you will not understand pathology. So, you compare with the normal. Mukhang normal ba? Alright. It is well differentiated. Hindi na ba mukhang normal? Ibang-iba na. It is undifferentiated or poorly differentiated. So that is the concept of our using the term differentiation. Does it resemble the normal? How far? The extent. If it resembles the normal, so that napagkakamalian mo na normal, that is a well-differentiated neoplasm. But if it is not, you do not know anymore, where did it come from? There is no more normal characteristic. That is undifferentiated, and you call that anaplasia. So, well-differentiated, o magkamukha sila. Moderately differentiated, konti lang. Pero ito, hindi na. Poorly differentiated na. Hindi na magkamukha, no? Parang ganyan. Yung kambal, magkamukhang magkamukha. Ito sa buhok, sa konting mukha, moderate lang. Ganyan din ang tumor, no? Pero pag hindi nakamukha, it is already poorly differentiated or plastic. So you can see here, no? That is the normal, normal size, normal size of the cells lining, you can see the lumen, see? And then you can see the normal well-differentiated cancer cells, pero tignan nyo ngayon, they are moderately differentiated. Iba na, nag-iiba-iba na yung korte ng cells, hindi na sila cuboidal na uniform. So, they're moderately differentiated. Meron pa rin normal. Yung poorly differentiated, wala nang, wala nang lumen halos, nagsiksika na doon, they are very, and they also gain increased staining, see? And then, look at the anaplastic or the undifferentiated. If you look at those cells, you will not think that they came from the normal, healthy glandular cells because they are already very undifferentiated. I hope that diagram will show you the similarity and the difference. So anaplasia is the lack or loss of differentiation. There are other morphologic changes besides differentiation. And remember, that is the hallmark of a malignant transformation. Cancer cells do not reverse from mature to immature. And like you have learned in metaplasia and hyperplasia, you do not originate the cells from the normal mature cells. They arise from stem cells that are found in the tissue. They are latent there. When they are stimulated, then they start to differentiate and produce the cell that is going to be growing there. It is the hallmark of malignant transformation. The moment you see anaplastic changes, that is malignant. So, what are the criteria? All right. So, this is one of the earliest and one of the criteria where you have the term pleomorphism. Pleo, they differ, they vary. And look at the cells here, they vary in size, they vary in shape. You do not know if they were originally squamous cells, they were originally columnar cells, wala na. They are very, very anaplastic. So, there is a variation in size and shape. There is already a random, there is no more alignment to glands, alignment to stratification, wala na. This is already very disorderly, varied size. Alright, then you look at the nucleus. Normally, you have nuclei, for example, called columnar cells. 1 part nuclei, 4 parts cytoplasm. 1 part nuclei, 6 parts neoplasm, cytoplasm. Pare-pareho yan. Tignan nyo sa glands, sa normal glands, pare-pareho. 1:4, 1:4, o kaya 1:6. Lumaki na yung nucleus. Kalahati na nung cell nucleus na. So, 1 part nucleus, 1 part cytoplasm. That is increase in the nucleocytoplasmic ratio. Meaning, there is enlargement or increased size of the nucleus. And that nucleus, because it increases in size, there is increased chromatin, it becomes darker in staining. So you call it hyperchromatic. And if it is not too dark, you will find inside that the nucleoli are also larger. Now, since they are growing very fast, you will have increased mitosis, and you should know the appearance of mitosis, and it can be atypical or bizarre. Now, one of the normal mitosis, you have two, you have the cells, the chromatin at the center, and it will be pulled on one side, on the other side, so you have two areas like that. And here, at around 6 o'clock near the center, there is a abnormal or a typical mitosis here where there are three. So you will find also at about 5 o'clock that there is a very, very large cell there. See, with the, it's almost 1-to-1 nucleo or 2-to-1 nucleocytoplasmic ratio, very hyperchromatic. Then the other cells, like you see number at about 9 o'clock, you will see the nuclei of the cells that are very buried, atypical, no? And sometimes they fold, they form a loop, something like that, and they are bizarre. So take into consideration the appearance of the nucleus, increased NC ratio, hyperchromatic with large nucleoli, with increased atypical mitosis. Another one is loss of polarity. When you say polarity, that means orientation. Look at the normal here. This is normal stratified squamous epithelium. You have a zone 1 at the basal cell on the right side. You have your zone 2 where you have the basal cell starting to proliferate upwards. And as it goes up, it becomes polyhedral, and you can see the stratification, the layering of the cells. And as they go up, they become more compressed. And in the second, you still have polyhedral, but as they go up, this is non-keratinized, so you can see compressed cells on the top part. In the skin, you can see that this is the keratin layer. There is a keratin layer. Alright, that is normal stratification. But when you disturb that stratification, that orientation, you will see now on the left side that the basal cells, parabasal cells, are up there in zone number 4. They're in zone number 3. So, it is already a disturbed orientation. And this is already loss of polarity. See? And this is considered already a precancerous change. Then you have also, because of the very rapid mitosis, you also produce cells that do not separate. So they undergo mitosis, but they don't separate. And what is produced, like for example on this, on the right side, you see a very large cell, and each cell retains its nucleus, but they fuse now to form a giant cell. And you can see the difference, the pleomorphic nuclei, you can see hyperchromaticity, etc. At about the, on the left side, you can see also plenty of nucleoli abnormal, plenty of tumor. They are tumor giant cells here, which are different in sizes, in shape, in staining, and that is also part of anaplasia. Now you have seen you have seen giant cells, like in TB, your Langham giant cells. It is similar to this because it's large. The nuclei are found at the periphery, but the nuclei are uniform, like a string of pearls. The horseshoe shape at the periphery in Langham giant cell. Here, the nuclei are very hyperchromatic and very pleomorphic. So, the Langham giant cell is inflammatory, but this one is a tumor giant cell. You have those anaplastic changes, and if you go back, you go back and back until you memorize the changes, because anytime you see cancer, you look for the anaplastic changes. Now, you have a differentiate between metaplasia and dysplasia. Metaplasia, you learn this in adaptive changes. When there is injury, there is damage, you replace one cell with another type of cell which is more resistant to that injury so that it will not be damaged. And so you also have damage, you repair, you grow new cells, and you have metaplasia. Now, dysplasia, the orientation, again, the polarity, the orientation, architectural orientation of the cells are lost. And the cells are not very uniform, they're not uniform anymore. So the growth is disordered. You can dysplasia, disordered. You can remember it that way, only the spelling is different. It's DYS, the other one is DIS. So you have a disordered growth, the polarity of the cells are already lost, the orientation of the cells, the uniformity of the cells, and this is considered, these two are considered pre-cancerous conditions because there is already disordered. Now, when you have metaplasia, look at these columnar cells. You have a basement membrane, there is a stimulus, and you will find out that from the stem cells, the squamous cells now will undergo proliferation and will undergo stratification and change metaplasia from the columnar to stratified squamous epithelium. All right, you can see there is already stratification, and like in cigarette smoking, the bronchial tree, that is already resistant to the cigarette smoke, unlike these columnar cells. Now, when you have in the skin here, it's inverted, the basal cells are up there, no? Normal. You have hyperplasia where you increase. Now, when it is already disordered growth, you can see that the basal cells are going up to the fourth layer, the fourth zone, the third zone. They are not limited anymore by the rules of growth, see? And these cells are not uniform anymore. Because here in the normal, as the cells go up to the stratified to the lower part there, they are being changed to spindle, and you have a change in the cells. But here, up to the uppermost, this fourth zone, it is already appearing like the basal cells. And cancer, look, what is the difference between the dysplasia and cancer? The cancer has gone beyond the basement membrane. It has invaded beyond in dysplasia, the basement membrane is still intact, but in cancer, you can see now those outpouchings going out there. They are invading the basement membrane, and that is a characteristic of cancer. So invasion, you can see the infiltration of the adjacent tissue, and sooner or later it will be destroyed. Now, this is a reliable feature that differentiates, as in the previous diagram, the benign from malignant. But number one, it is only second to metastasis. Invasion is number two. The reliable feature is metastasis. Now, if it is a benign tumor and they grow, the cells increase in number in the stroma there, you see they crowd, they push on each other, they crowd, so that they push on the surrounding connective tissue. And as it gets bigger and bigger, the connective tissue becomes compressed. And that connective tissue is the connective tissue of the tumor and the connective tissue of the adjacent tissue. And it forms a capsule. And that capsule actually limits also the growth, the rapid growth of the cells, because they have to push and push against that capsule. And that is the compressed connective tissue. And so most of the encapsulated, your primary tumor, and you can see that it is going outside and invading the adjacent tissue. See? Now, when you have extravasation outside, you can see from the left side, primary tumor, then you have a localized invasion, Then you have invasion of the adjacent tissue. Now look at the basement membrane there, and it is going out. Where? It is invading the wall of the blood vessel. So inside, they can survive inside. And as they get smaller and smaller, o hindi na siya makadaan, they will be blocked, smaller vessel, and then on the left side, they will go out. When they go out of the blood vessel, they continue growing small, that is micro. Then you have a colony there, and you can see now that in that patient, it has gone to the brain, it has gone to the lungs, it has gone to the liver, to the arms. That is already metastasis. It is already clinically detectable because it can be palpated, it can be seen in X-ray, it can be seen by tests. So you have a benign tumor that is expanding, and it keeps expanding against the surrounding tissue. These are normal cells, but they form a capsule. But if it is malignant, it will go out and the margin will not be very well defined, and they can go into the blood vessels. And what about the tissues that they are going to damage? Then they will be necrotic. You have the death of the cells, see? And you can see now that you have the anaplastic changes here, they are abnormal, they have pleomorphism, but the important thing here is so here now is a metastatic tumor. It is in the lymph node, and you can see that these cells are tumor implants. They are no longer connected. It looks like epithelial. They are no longer connected with the original tumor, the primary tumor. And that is the concept of metastasis. The word discontinuous, nakahiwalay na. That is the concept of metastasis, na humihiwalay na from the primary tumor, cancer cells. So, if you are asked to define metastasis, these are tumor implants. Don't forget the keyword, discontinuous with the primary tumor. Kasi kung nakakabit pa sila sa primary tumor, hindi pa yan metastasis. That is just invasion. Alright, so again, you have the primary tumor and you have metastasis. Napunta pa ulit, no? So, they invade, nandun lang, nung pumasok na sa blood vessel, naipit na doon, lumabas na, okay, and micrometastasis muna, nung lumaki na, may colony na, and clinically, that can already be detected by the ultrasound, by the x-rays. So metastasis is a tumor implant that is discontinuous with the primary tumor, and that is unequivocal. Ibig sabihin, walang duda. There is no more doubt that that tumor is malignant. Most of them can metastasize. Again, you memorize this because dalawa lang naman sila. That is gliomas of the CNS and the basal cell carcinoma of the skin. Remember, this basal cell carcinoma can invade. They can invade through the skin, down to the underlying muscles, even to the bone, but they rarely metastasize. That is why that is considered an exception. Now, if the tumor is more aggressive, meaning it is growing rapidly, it is growing fast, larger, then there are more cells, and of course, there is a greater likelihood of metastasis. Now, nakalat na. What are the pathways of spread? So, you have seeding of body cavity and the surfaces, seeding, and you have lymphatic and hematogenous. Now, ano ba yung body cavities? When we ask students, what are the body cavities? Immediately they say the pleural cavity, the abdominal cavity, o ano pa? Wala na. You have still other cavities like the synovial cavity in the joints, and you have the subarachnoid space, which is still a cavity there in the cranium. See? So you have that. And if the cells will separate like you have seen there, they separate from the mother tumor and then invade into that cavity, you have seeding. This is based on a parable in the Bible. Those of you who know this, that it is like the word of the Lord, like the seeding, where there is a farmer who is carrying a bag of seeds and he gets a handful and throws it around him. And the seeds that fell on stones did not grow. The seeds that fell but were eaten by the birds did not grow. But the seeds that fell on healthy ground grew. And so, that is the concept. That if these seeds, this tumor, these cancer cells, will get into the cavity and fall into the cavity, if they see a space or a place where they can grow, meaning they have a good blood supply, they can have the needs supplied for their growth and development, they will grow. And this is a common one where you have a cancer of the stomach, and the cancer of the stomach will invade the wall, will reach the serosa, and the cells in the serosa will fall down into the abdominal cavity and will get to the surface of the ovary. Why the ovary? Because you have a good blood supply on the surface there, and this adenocarcinoma of the stomach will grow in the ovary. They call it the Krukenberg tumor. See? And also, this is in case of the appendix. The appendix is part of the GIT. It can also have a cancerous growth. And this cancerous growth may also get out or rupture and spill the cancer cells into the peritoneal cavity and form the so-called pseudomyxoma peritonei. This is appendiceal cancer. Now, there is also lymphatic spread. Initially, it is carcinoma, meaning it is epithelial. But sooner or later, even the sarcomas, even the mesenchymal cells can go to the lymphatics and vice versa. So the initial pathway of spread of lymphatics is by the carcinoma cells. So you have lymphatics, it's a one-way road draining the tissue. And let's say our example is in the breast. You have the breast usually draining through the axillary lymph nodes. Sometimes they skip metastasis. They do not drain specifically in that area, but usually to the axillary lymph nodes. And so, if a patient comes with a mass in the breast and the doctor suspects there is cancer there, he is also going to inspect the axillary area to palpate for lymph nodes. Because if he will palpate several enlarged nodes and think and get a biopsy and there is cancer there, then he will have to do a radical operation where he will remove the breast, the pectoralis, and the axillary lymph nodes. But nowadays, they prevent this or they minimize this by getting the so-called sentinel nodes. This is, if you have a sentinel, it is a guard there at the gate of your subdivision, and he is the first one that will accost any stranger that will come in. So that's the same. The sentinel node is the first nodes that will be draining the lymphatics from the breast. And if there are cancer cells, they are usually trapped in the sentinel nodes. Or if there is negative, the sentinel nodes are clean, then the surgeon concludes that the cancer cells have not metastasized yet to the lymphatics and may not get the axillary chain anymore. So he may not do a radical operation anymore. All right. And The lymphatics, where does it go? It goes to the right side of the heart, to the lungs. Now, hematogenous, the initial is for sarcomas. And sarcoma, you have the mesenchymal components that will go into the bloodstream, and like in the diagram, it will have to go with the blood. And if it will go with the blood, usually it will attack first the veins, because the veins have thinner walls. So, the right side of the heart, they go to the lungs. That is why the lung is very frequently involved. Now, the liver has another circulation there, which is the portal circulation, draining a large amount of material there in the GIT, and it passes to the liver. So, you have also the liver that is most frequently involved for metastasis. This is a summary of what we have talked about, and you have a summary like this, where you have 4 criteria: differentiation in anaplasia, rate of growth, invasion, and metastasis. The differentiation is well differentiated for the benign, but there is a wide, um, you have also well differentiated from the malignant to poorly or undifferentiated or anaplastic. That is the problem of some of the pathologists. If you have a well differentiated liposarcoma, it looks like the normal, you see, because we say when it is differentiated, it resembles the extent to which it resembles the normal, and a well differentiated liposarcoma resembles the normal. So you have to do other tests so that to show whether that is really a liposarcoma. But when it is anaplastic, then you know already that you have already all the criteria of an undifferentiated tumor. Now, the rate of growth is benign, of is indolent, slow growing, especially if there is a capsule, because they have to push and expand the capsule. Whereas malignant cells usually grow rapidly, but sometimes they slow down. The patient says the tumor did not increase in size for a few months, but it is therefore erratic. Now, the two, invasion and metastasis, you don't see that in benign. That is a characteristic of malignancy. Number one is metastasis, and number two is invasion. The invasion may be progressive, and remember that as it goes out into the tissue, it destroys the surrounding or. So let's go to epidemiology of cancer. There are cancer patterns in different regions, and therefore a lot of research is being done about the origin of this cancer, the causes of cancer, which is usually from the environment. It is also genetic or hereditary, and it has a cultural influence. And there is an ongoing statistical survey where you have the incidence of cancer going up or going down. One of the examples of cultural influences in the Philippines is the betel nut chewing, nga. I don't know if some of you come from the provinces, if you still have that practice among the elderly. Usually among the elderly, before, it used to be among the adults. But now, there is a lesser incidence of that cultural. Uh, it is still found in some provinces, but it is the elderly are usually with that. They have betel nut, but they have a concoction of leaves and tobacco, and so this is chewed. It stays in the oral cavity for some time, and the concoction there, once it is chewed, in fact it becomes red, and you think that these women have lipstick. But then they found out when they did a study that a lot of these betel nut chewers have a higher risk of developing oral cancer of the epithelium the gums, see, the tongue. That is an epidemiologic study on cultural influence. Now, this was in 2017 already, and you can see that the highest incidence of cancer is in the prostate gland in the male, the lungs and bronchus, and then the colon and the rectum. In the female, it's still the breast, 30% in the breast, the lung and bronchus also, and colon and rectum. So second and third is the same for male and female, but the incidence is higher in the breast and in the prostate, according to the sex. Now, take note, if it is high there, you would think that it is the one that will give the highest mortality. But look, the higher mortality of both is in the lung. It is only 15% in the breast. That's number two. And you have the pancreas and the colon in the female as 8%. Now, also in the male, it's also the lung and the bronchus. And then the prostate is the next, 10%, and then you have the colon also in rectum. So it is not okay that if you have the most cancer incidence, it is the one that will kill the patient. No, it is the lung and bronchus that is the cause of mortality in the 20s. So you have virus caused by human virus. You have decreased death rate in the women because of the diminution in the death rate from cancer of the breast, colorectal CA, and even the cervix. Why? Because from the time that they started to do the pap smear, actually that is Papa Nicolau smear. This is an exfoliative cytology procedure where you brush with a spatula the superficial cells of the cervix. If there is cancer there, these cancer cells separate, will go with the spatula. You can put that on the slide and you can see those cancer cells in the slide, in the smear. No? And they can diagnose cancer therefore earlier where it can be still cured or minimized in its spread. So that is the same with cancer of the breast and colorectal cancer with the addition of these um, tests. Like you have in the breast the fine needle aspiration biopsy, the needle biopsy. In colorectal CA, you have also colposcopy. They can see already. You can get a biopsy. And you can see that more than nearly 80% total decrease in lung, prostate, and colorectal cancer in the. Now, there are many factors, and this will be you will determine what aspect of that factor will be producing stimulation of abnormality in the genetic makeup of the cells, genetic injury, so that you will find clone of cells. And we will take about the inflammation that is with infectious agents. In smoking, it is the presence of the stimulus by um, the toxic fumes, carcinogenic contents of cigarette. That's why there is almost a ban on cigarette smoking in public. Alcohol usually affects the liver, and it is the consequence of that liver inflammation that will be producing the cancerous growth. In the diet, there are carcinogenic agents that are admixed with the diet. Obesity is usually with also with the diet, with diabetes. Reproductive history is the presence of hormones during reproductive period, which might be protective to the woman, but the moment that there is no more protection, then you have already carcinogenic influences. There are a lot of environmental carcinogens. You will take that up in environmental pathology. Like you have miners, who are exposed to carcinogenic substances, like there are a lot in the environment um, that may be carcinogenic. Now, what is the age of people who get cancer? Usually more than 55, the elderly. Is the leading cause of death among women 40 to 79 and 60 to 79. But in children, you also have 60% death, and usually leukemias. Many of those who are in the cancer uh, institute, cancer hospitals had leukemias and neoplasms of the CNS. Now, there is a group of neoplasm which consists of just small round blue cells. They look like small lymphocytes. They're very similar that you have to do a lot of tests to differentiate one from the other. You will be taking them up in relation to the systems. So you have a neuroblastoma, venous tumor, which is in the kidney, retinoblastoma in the eye, leukemias, and muscle, rhabdomyosarcomas. When they are anaplastic, they will produce small round blue cell tumors that are very similar to. Now, predisposing conditions. You have chronic inflammation and precursor lesions and immune deficiency states. We will take that up one. So you have chronic inflammation with hepatitis, with pancreatitis, inflammatory bowel syndrome, gastritis, and in all of this, you can see, and you have seen that in your lectures on inflammation and repair, that together with chronic inflammation, there is already side by side repair mechanisms. There are plenty of cells, the inflammatory cells, the tissue cells that will produce cytokines. Now, what are cytokines? In one of the SGDs, I was asking what are cytokines, and nobody could answer, and yet they were saying cytokines. They are messenger molecules of the immune system. Messenger molecules of the immune system. They will go to cells and stimulate or suppress. See? So you have a lot of cell proliferation due to uh, stimulation by cytokines. So you also increase the pool of stem cells. Remember that if you will grow new tissue, you get it from stem cells. And one of the reactions is producing the reactive oxygen species, which will give rise to what? Free radicals. So you have in some cancers an increase in this reactive oxygen species, COX-2, for example, increased in colon cancer. Now you have also precursor lesions. When you have precursor, meaning they are giving a high risk of cancer to the patient. And that can be detected now by screening procedures. And there are three here mentioned. You have a metaplasia, hyperplasia, and leukoplakia. When you were taking up adaptive changes, that was already mentioned to you. That in some conditions, not in all, but in some conditions, that may give a higher risk of malignancy or cancer brought to the patient. Like, for example, that cigarette smoker, chronic cigarette smoker, you see, so that with that chronic cigarette smoke that is already stimulating or injuring the lining of the bronchial tree, there will be an adaptive change, and that is a metaplasia. But you can see that that metaplasia will change to the columnar to stratified squamous epithelium. And the statistics show that lung cancers among heavy cigarette smokers, you have a predisposition to form a squamous cell carcinoma. And you say, saan ang galing yun? Squamous cell. Ang lining niyan ay columnar because of the metaplastic tissue. See? Alright, hyperplasia. You have also hyperplasia, which is an adaptive change, which is a good adaptive change. But let's say in the uterus, where you have hyperplasia, the ordinary hyperplasia will bring about bleeding, changes in menstruation. But when you have a complex hyperplasia, where the growth may start to be disorderly, then you will have a predisposition, you see, to cancer formation in that endometrium. And leukoplakia, like you have a chronic irritation in the gums, and it will also change and it will thicken, and you have also exactly a metaplastic change, but this one may even have keratinization, but it also has a high risk of developing cancer lesions. And of course, it follows, no, that if the patient is immune deficient, especially in what? The T lymphocytes. Why? Because it is stated in your immune chapter that our basic um, defense against viruses is the cellular immune system, because viruses go inside the cell, and we need these T lymphocytes to kill those cells or produce cytokines that will produce inflammation that will kill the cells with the virus. So, in immune deficiencies caused by the virus, you will have no more defense. You are defenseless against these uh, changes in the genome of the cell, injury to the nucleus of the cell. All right. Now there is also we call non-genetic factors, and these are the so-called epigenetic factors. No, that was part of the that is part of the chapter on neoplasia, where you have genetic changes in the DNA, for example, in the nucleus, but you have also no change in the DNA, and yet there is also cancer formation. So you will find out that there is genetic and non-genetic factor in the development of tumors, and there are many contributory factors. But this is a genetic factor in this example, where you have a change in the genes, where you have the so-called BRCA, breast cancer 1 and 2 mutation. And there are women who are carriers of this type of mutation in their cells. Actually, they saw a 3-time increase in women born after 1940. I do not know why. But one of the reasons is in one P40 450 loci, there is already change there, where you do not have only monoclonal changes but different alterations in the clones. So you will find out that uh, do you know of the story of Angelina Jolie? You see, Angelina Jolie is married to, who is that male actor, and a relative of hers, I do not exactly know her sister or relative of hers, had breast cancer, and they looked for the mutation that were that was found in this patient, and they found out that that patient was positive for the BRCA and 1 and 2 mutation. And Angelina Jolie had herself also examined, and they found out she was a carrier of the BRCA1 and 2 mutation, according to the story. And at that time, this was a few years back, at that time, there was a statistical study done on these carriers, and they say that there is more than 75% risk of developing cancer as the carrier gets older, of developing breast cancer. 75%. That's a very big possibility. And Angelina Jolie, she had no mass in the breast. She had very nice figure at the height of her famous career, had both of her breasts removed. And when she was asked, accordingly, allegedly, she said, I do not want to be worrying that when I get old, I will have breast cancer. So she might as well have the breast removed. Anyway, she did not have children to suck from my breast. And even after that, her form was still very good because nowadays you can have the breast removed and have it replaced by artificial breasts. See? And this is related to the BRCA1 and 2 mutation carriers. Also, in lung cancer, there is an inherited susceptibility. But if that patient, you see, does not smoke, he may not develop the cancer. But he will risk developing cancer if he has already that susceptibility and then he still will go on smoking. That is why there was very high rate of lung cancer among heavy cigarette smokers. Now, in carcinogenesis, it is not enough that you will be exposed to the carcinogen because there are two phases of carcinogenesis. One is initiation, and that is because the cells have been exposed to that sufficient dose. And I said sufficient dose because sometimes it's not sufficient, and even if they were exposed, they did not develop any cancer. See? But that exposure produced already a permanent DNA damage. And the moment that DNA damage is produced, it is irreversible. It is rapid, irreversible, and it has memory, meaning if the cells will divide, the daughter cells will also have that DNA damage. Alright, but you have a carcinogen that initiated the damage, and that patient can just have that damage all throughout his life and not have any cancer because he has not been exposed to the promoter. Because once the cell is already initiated, then you will have induction of the tumor, see, by a promoter. So it will affect directly or indirectly, but irreversibly, the initiated cell without being affected. See? So the initiators, these are carcinogens that are direct acting, they are highly reactive, but these direct acting are usually weak carcinogens. The indirect acting will require a metabolic conversion. So there are chemicals that have to be converted, drugs that have to be converted to become a carcinogen. And that means they require activation by cytochrome 450, P450, dependent on the monooxygenases. So individuals who have been exposed to the carcinogen may have a varying reaction. See, varying reaction. So you say there is a carcinogen in that mine. Why is it only that 3 miners were affected, the other miners were not affected? Because of the varied reaction among individuals. And it can be initiated by direct acting or indirectly acting. So even if you are exposed but it is not converted to the carcinogen, then it will not have. Now the promoters, they are not mutagenic, but they will stimulate now in the initiated cell, they will stimulate the cellular proliferation. A very good example are hormones, some esters, phenols, and some drugs that will stimulate cellular proliferation in the initiated cell. But I said, if these patients who have initiated cells are not exposed to these promoters, Well, they just carry that initiated cell throughout their life without any tumor formation. So you have carcinogenic chemicals. Remember, indirect acting or directly acting. Some of them are alkylating agents, weak direct acting, and you have chemotherapeutic agents. The ones that they use for treatment can also be carcinogenic. You have polycyclic hydrocarbons, and this is where tobacco smoke and smoke waste will enter. You have also in the diet aromatic amines, diazo-dyes. That is why the FDA is very particular about the food colors that are being used. See, in the industry of food industry. Now you have also these chemicals occurring in nature, like aflatoxin B. Did you know these are found in peanuts, corn, and rice that are stored? If they are not stored well, then they become humid like the peanuts, and fungi are going to uh, proliferate there. And the peanuts that will be affected by this fungus will have the aflatoxin in the peanut. And you will say, oh, if it tastes bad, I will not eat it. It does not taste bad, you see, but it contains aflatoxin. And when they gave this aflatoxin peanuts to turkeys, in 4 to 5 months, they develop cancer of the liver. See? You have also nitrosamines, and amides, and usually these are used as preservatives. They use that as preservatives usually for the meat or fish. That is why again there are many who says in their menu that they do not use the beef, they use fresh beef because it has not been no preservatives. There are others like asbestos, vinyl chloride, asbestos in mines also. Arsenic also is found in mines, industrial exposure, even insecticides that are used by the farmers. They have to be very well protected when they are spraying their farm. Now, another etiology is radiation carcinogenesis. There are two types. Actually, the ultraviolet and ionizing electromagnetic with some particulate materials, like in the atomic bomb explosion, where you have the alpha beta particles. See? Now, there are three types of ultraviolet light, A, B, and C. The A is the one that's very mild. They even put that in lumps and they do those whites may get a tan under these lumps with the ultraviolet A. But it is the B that will penetrate the skin and link to forms of skin cancer. Very commonly squamous cell carcinoma, basal cell carcinoma, and melanocarcinoma. These are the three types of cancers that are very common as in patients who've been exposed to the ultraviolet B sunlight. That's why they also say if you go to Boracay, you're exposed to longer period of time, bring your sunblocks, you see, so that you will block the ultraviolet. But these are also going to uh, affect people who are in the sun all the time, like farmers, for example, see, and laborers exposed to the sun all the time. Now, the basic change is they form pyrimidine dimers in the DNA. The nucleus is involved. However, that can be excised. That can be removed. It can be removed. Then you don't have the cancer. But that dimers are the ones that will stimulate the proliferation of the cells. You have also ionizing electromagnetic forces, X-rays, gamma rays, and again, it is the nucleus that is the target of this DNA in the nucleus. That's why you say, what about the X-rays that they use for the lungs, for the bones, etc.? They is very, very low dose, low dose. And the effect of these particulate particles is shown in the survivors of the atomic bomb blast after the World War II in Hiroshima. Many people died, but there were survivors who survived but were exposed to the atomic rays. And they found out later on the survivors developed a lot of cancers, leukemias, usually skin, after about 10 to 15 years. So it is the change is very slow, very latent, but eventually there is a destruction. Now, what about microbes? Well, we have the bacteria and the viruses. The bacteria, there is only one bacteria involved. But a lot of the viruses, you have two types of viruses, the RNA and the DNA. There is only one RNA virus involved in carcinogenesis, and that is the RNA virus, human T cell leukemia virus. This is a T cell leukemia. It can also produce a lymphoma, benign or malignant. That is malignant, remember, because they have the so-called TAX in the gene, and that produces a genetic instability and proliferation of the cells. Now, the RNA virus C, hepatitis C, also is supposed to be included, but the mechanism is not well understood. It is more of the B. Now here you have the bacteria, the only bacteria involved. Maybe one of you will be able to discover another bacteria, but this is the Helicobacter pylori, which lives in the stomach. Now, the stomach has a very high acidity. How can the bacteria live there? See, the bacteria has a lot of ways by which it can um, protect itself from the high acidity of the of the gastric mucosa, and it can also now produce the so-called CAG gene, CAG-A gene, and cytokines, which will produce inflammation. That is why it is associated with gastritis. There is a chronic inflammation, and eventually there may be atrophy of the epithelium, but with the production of with these bacteria and the genetic abnormality, the cytokines, you have an adenocarcinoma growth there. Now, what is a maltoma? You have in the lymphatic system, so-called the marginal lymphocytes. So you have the marginal lymphocytes that are affected here, which will also be stimulated to produce a type of a lymphoma. You call it a maltoma. Now, we go back to the virus, and you have the DNA viruses. You can see a lot of them here, especially the Epstein-Barr virus. It produces a lot of the neoplasms that may be in the lymphoid tissue, like Burkitt's lymphoma, B-cell lymphoma, and HIV usually, because HIV is immune deficient, Hodgkin's lymphoma, and a nasopharyngeal lymphoma. It produces a protein which is oncogenic, you see. Now, the human papillomavirus, there are many viruses, but the 16 and 18 is the one that is associated with the squamous cell carcinoma of the cervix. And because they have oncogenes, the oncogene E6 and E7, and this will affect the proliferation. For example, E6 is going to activate the MYC gene, which is proliferating the cells, and E7 is going to mutate a tumor suppressor gene that is protective, so the cells will not be suppressed. They will be stimulated to grow. No? Now, the hepatitis B virus is more studied than the hepatitis C. And you can see that you have also the hepatocellular carcinoma, they call it hepatoma also, because of the chronic inflammation. Our precursor lesion, remember, is a chronic inflammation where you have repair processes, you have cytokines, reactive oxygen species, and it is that repair process that will be seen in a chronic inflammation of the liver, where you have a chronic hepatitis, which may be associated now with a precursor to the liver cancer. We also have the herpes virus 8, which is associated with a type of sarcoma because you have proliferation of uh, blood vessels in the skin in cases of the herpes virus 8. So these are examples of viruses that can also cause or trigger the proliferative change. Now, what about the tumors? What is the complaint of the patient? The clinical features. Usually they complain locally and hormonal, but sometimes you have the so-called cancer cachexia and paraneoplastic syndromes, which sometimes fool the doctor. See? Now, local effects are the one that are common, like you have the tumor growing into the lumen of the intestine, and you have intestinal obstruction. You have compression of surrounding tissue, like the pancreatic head may be enlarged with the tumor, and it will be compressing on the bile duct, and you will have jaundice because of obstruction. You have the impingement on vital tissues, and especially in the brain, where you cannot afford to have an increasing mass in the brain, because any tumor there that's going to grow, whether it is very small or getting bigger, will produce what? Increase intracranial pressure. And there will be compression of the vital tissues around that tumor, see, like a pituitary adenoma, which is at the base of the brain. Now, you can also have, because there are many cells, they may hyperfunction or they may be so immature that they do not function. So you can have primary or metastatic neoplasia to endocrine organs with a hyper or hypofunction. A very good example is a tumor of the beta cells of the pancreas. What do the beta cells produce? They produce insulin. And if you have plenty of these beta cells, you have plenty of insulin, what do you expect? That patient will be fainting all the time because of what? Low blood sugar. See? Because of the excess insulin, this patient will have low blood sugar. And again, in the GIT, like I said, you can have obstruction. And intussusception is, it will pull the tumor in the intestine, will pull one part of the intestine into another part. That is called intussusception. It goes, a part of the intestine will be enveloped inside another part of the intestine because of that tumor. And a common one is erosion and destruction, like you can have in the renal, in the kidney, you can have destruction of the glomeruli, and you will have hematuria because you will have a lot of bleeding there. Or you can have in the GIT, like in the stomach, you can have a tumor there, and you will have bleeding. And remember, when you have an upper GIT bleeding, you will hemolyze red blood cells, and the red cells will be hemolyzed and produce a tarry stool because of the iron that will be freed from the red blood cells. So a cancer in the stomach can ulcerate and be suspected to be an ordinary gastric ulcer, but when they find out that the bleeding, there is already invasion, or you have a scope that will be showing the growth in the stomach. See? All right, so you have this local and hormonal effect if it is endocrine. Now, have you had the chance of visiting a patient who has been cancerous for a long time? And you say, when you go back, nakakaawa naman si ganito, binalalaw ko. butot balat na lang. Okay. So that is a patient showing cancer cachexia because there is progressive loss of body fat, nangangayayat na, pati yung mga laman, lean body mass. The patient becomes very weak, anemic, and especially it is augmented, exacerbated by anorexia, di magana kumain, the BMR is elevated, and usually there is a inflammation somewhere in the body. You have a systemic inflammation. And there are many factors that are found here in cachexia. And you have these destructive factors like tumor necrotic factor A, which is cathexin, interleukins, which will produce inflammation, destruction of tissues. So you can see now that from the cancer cachexia, you can see the ribs, the arm that is filled with muscle is now bone, skin and bone. The clavicle is very superficial. The muscles atrophy. You can see in the left side of this person with a good muscle, and you can compare that with the atrophy there where the muscles are very thin already, and it is just the outline of the bone that you see. The bones in the face will also be very prominent already, the cheekbones. That is cachexia because of the loss of the muscle and the lean body mass and the fat. Now, this is a syndrome. When you have a syndrome, you have a complex manifestation. Hindi lang iisa, may lagnat ako syndrome na, hindi. There is a complex of manifestations. And you cannot explain that in this patient with tumor, hindi naman nag-metastasize. There is no hormone production. See? And usually, this is found in about 10% of persons with cancer. Sometimes the neoplasm is only a occult. You hardly notice it, but you will have early manifestations already. And usually that can be significant because you might be thinking you are treating one condition and the other condition is not treated. See? It may mimic a metastatic disease. And again, you will be treating the condition as a tumor that is metastatic when you will miss the original tumor. So it can produce endocrinopathies, neuromyopathies, or dermatologic conditions. And one of that very common is a Cushing syndrome, which that syndrome is produced by adrenal insufficiency. But you will find out that you can have a cancer of the lung or cancer of the kidney that will produce a Cushing syndrome. And you are concentrating on the adrenal, you see? Or you can see here your parathyroid proteins that are being produced by parathyroid hormone producing hypercalcemia. And then you are looking for bone conditions that will produce hypercalcemia, and yet the original condition is parathyroid. Or it may be neuromyopathic syndromes where you have myasthenia, where you have weakening of the muscle, and you do not know where is the origin of that. See? And it might be just a cancer of the pancreas or something. It can be dermatologic because the tumor is producing substances that will prevent the death of abnormal cells. It can be also osseous, like it looks like already you have a arthritis, you have a hypertrophic osteopathy, arthritis, clubbing of the fingers, and yet it is due to another tumor. See? And very common, you have the small cell carcinoma of the lung or small cell carcinoma of the kidney that can be producing this paraneoplastic syndrome. It can also be vascular or hematologic. There is a story here about that migratory thrombophlebitis. This is related to a Frenchman. His name is Mr. Trousseau. And he was complaining of this thrombophlebitis. Thrombophlebitis, you have Phlebitis, inflammation of the veins with thrombus formation. It is very painful and it transfers from one side to another, you see. And they were concentrating on the blood vessel pathology. And then one doctor gave it a complete physical examination and found out that it was a pancreatic cancer. Ang layo, ang layo. A pancreatic cancer that is producing a paraneoplastic syndrome that is giving rise to that migratory thrombophlebitis. That's why they called it that migratory thrombophlebitis. If you see it in some of the medical books, they call it the Trousseau syndrome, after the name of the original patient who had the cancer of the pancreas with the paraneoplastic syndrome that we're showing as a migratory thrombophlebitis. So there are other syndromes like a thrombotic endocarditis, see, or a DIC, and yet the origin of that stimulation is from a cancerous condition. All right, so how do we grade end states? You see now we are going to separate our discussion of molecular pathology in your next lecture. We are not going to touch on any molecular pathology, maybe a little bit here, but the molecular pathology is all lectured in one sitting. So in the diagnosis, there is a grading and staging of tumors. Now that's different. When you grade, you have to get a biopsy. You have to see the tumor. Look at the cells. How are they differentiated? How many mitosis? Because you have usually grade 1, 2, and 3, and 4. Grade 4 is where you have the highest anaplasia. And grade 1 is usually well differentiated. So it goes from the well differentiated to the very anaplastic tumors. That is grading, and you base it on the histopathology of the tumor. Now in staging, this is more clinical because you look at the primary lesion, you measure that, where is it, how big is that breast mass, you see. You examine the patient thoroughly for lymph nodes, usually the regional lymph nodes, and then you look for the presence or absence of blood-borne metastasis. And usually in the clinics, we use the two-staging system. The first one is commonly used, the so-called T&M, that is the international. Another one is American Joint Committee, but it is the T&M that is used. So in grading, you have to look at the cells, you see, where it is well grade 1, it's well differentiated yet, but then it will now undergo a differentiation about 10 to 75 of the tumor still form glands, but if you look at grade 3, you have 10% only less than 10% will form the glands. Now, if we look at the nucleus in grade 1, these cells are still uniform, small nuclei, maybe mitosis is 7 per high power field, but in grade 2, it's already pleomorphic, you have cells larger, they have vesicular nuclei, the size and shape, and more mitosis, 8 to 15. And with grade 3, you have already nuclear pleomorphism, you have prominent nucleoli, variation in size and shape, more mitosis, about 16 mitosis. See? Now, in the TNM for staging, this is now staging, you look for tumor size. So in the clinic, you measure the tumor. You also look for the lymph nodes, so you have to know where to look for the lymph nodes that will be draining the area, and you look for metastasis. All right, so it is TM. So you have staging different from grading. So you have also histologic, cytologic method, like you have a biopsy where you get a piece of the tissue. Usually now we use in superficial tumors, not in the deep ones. We use the needle aspiration. We have two types of needles. The more common one is the fine needle aspiration. You can do that in your clinics. And the other one is a bigger needle where you have the core needle. And of course, the pap smear where you just use the spatula to get the surface tumors. Now, immunohistochemistry, you categorize because sometimes you don't know what this it is so undifferentiated. Saan ba nang galing ito? See? So that you can look for the original tumor. But if it's undifferentiated, you don't know. So you do immunochemistry so that the undifferentiated malignancies can show where the origin, the site of origin. So you can, if it is from the prostate, you see it's already in the lung, it's already in another metastatic site, then you can go to the prostate and examine the prostate for the original or the primary tumor, the site of origin. Now, in the clinics, you have statistics. They have a study of what type of molecules have good prognosis, have good therapeutic values, and you will find out that in reading the tumors, you will find that some of them are resistant to chemotherapy, they're resistant to radiation. So it is useless if you will have the tumor and then have the patient irradiated because they are resistant, you see. And sometimes the molecules can guide you which are the immune resistant, which are the therapeutic resistant. Now, there is also membrane antigens in liquid tumors, so they look for the DNA content and the antigens by flow cytometry. However, you have an array of the molecules, and this is the DNA assessment of the sequences that are found in the DNA molecule. So you have signature genes, and you can also deduce by studies, clinical studies, the prognosis of the patient with certain genes with poor prognosis and certain genes with good prognosis. Now, sometimes you have treated the disease, and then you find out that there may be something left behind. So you can also do molecular diagnosis for residual disease and again hereditary predisposition, like you look for those abnormal genes in cases of carriers. Now, there is now the so-called guiding therapy. The other name for that is targeted therapy, which is personalized because different tumors in different individuals may show variations. So they look for certain tumor markers and or they look for tumor causes which you can inhibit, and the targeted therapy there is you give the inhibitor. So again, you have to know when you get to tumors what are the immunotypes of the tumors so that you can have a guide in treatment. So these are examples also of tumor markers, like in you have the choriocarcinoma where you have trophoblastic cells producing the human chorionic gonadotropin. You have hepatocellular carcinoma with alpha fetoproteins. In cases of the colon and the pancreas, you have the carcinoembryonic antigen, the prostatic specific antigen, and you have in cases of neuroblastomas, ovaries, colon, and pancreas, where you have these tumor markers. They are numbered, and you have others in the breast, for example, the TP53, which you know is a tumor suppressor gene. So that we battle against cancer, not once every day in our immune system. Remember, it is our immune system that will destroy the cell that would have to become cancer if it lived. It is the immune system that will detect. See? For example, you have viruses that are going to invade the cell and may have a risk of producing cancer. This is going to be destroyed by the immune system. So basically, our main defense to neoplasms is our immune system, specifically the CD8 positive lymphocytes, which is the T8 or the cytotoxic, which will go to the cell and bore a hole in the cell and destroy the cell by apoptosis. Or you have the T helper cell, which will produce cytokines, which will induce inflammation, and the inflammatory cells, inflammation, inflammatory reaction will react. So basically, the immune system is very important. That is why the immune deficient patients have higher risk of developing cancer. All right, so it will be continued with molecular pathology of